Hi, I'm Navid Gafar-Zadegan. I'm a faculty member at Virginia Tech. And today I'm reporting a project on modeling COVID-19 in collaborative work with my colleague and friend, Haji Rahman Dot. There have been many studies on the topic of COVID-19, and we have been learning from various research projects in different parts of the world. And throughout the projects that we are observing, there is one simple and very puzzling question that still remains, seemingly simple question. And that's about how many people are infected. Within the same line, you can ask how many people have died from COVID-19. This is a seemingly simple question, but it is also a very important question because it has serious policy implications. We would like to know how fast the disease is spreading, and throughout the process, we want to make important decisions about when to open the schools and how to expand the tests, how we should allocate our resources, and so on. So all of these questions will be influenced by our estimation of the spread of the disease. Importantly, underestimation of the cases is very detrimental for the society because people's perception of how serious the situation is going to influence their behavior. So if we underestimate the cases, it will lead to higher risk in the society, and more people will die. So this is an important question, but why it is difficult to have a good answer for that? Because if you think about the phenomenon that we are dealing with, our data is coming mostly from tests, and these tests are not 100% accurate. There are many cases that are missed. And the whole process of testing is delayed. There are different stages that the test should go through. And in different places around the world, test coverage is different. Test coverage is not perfect. And over time, it has been changing. We can add other things about this phenomenon that we are dealing with, which adds again to the complexity of the situation. Our observation of the situation and how numbers are reported in media are influencing people's perception of the risks, and is influencing how they react to the situation, how much they engage in social activities. So we are dealing with a phenomenon that our observations are also feeding back to that phenomenon. We are living with a problem that is influencing our behavior, and our behavior is influencing the problem. Moreover, the tools and techniques that we are using to understand the problem, all these test tools are changing, and the coverage of the tests are changing. So over time, it is also difficult to compare different data points together because all these instruments have been changing. So we are learning about the problem as things are happening. But many of the situations that humankind deals with has a similar characteristic. But here the issue is that people are also dying. So it is a very serious and urgent challenge. And our response should be timely to the problem. And when you include all these uncertainties with the need for timely response, you kind of feel that, okay, it is important to use all techniques and tools available to understand how the disease is spreading. And that has been our objective too. We use a model-based simulation approach to estimate the cases of infectious disease. And throughout this process, we are offering a dynamic and behavioral model that includes how people are reacting to the problem. We are using different estimation techniques to estimate our parameters based on any available data. And we are aware that there's always a trade-off on how complicated your model is, how much details you have, and the estimation accuracies that you are getting for your parameters and usefulness of your model. Here, the usefulness is also linked to how timely the solutions are offered. The case that we looked at was the case of Iran. However, all these methods that are developed in this study can be applied to other settings. But Iran was one of the early epicenters that still is dealing with the problem of COVID-19. So the first cases of confirmed COVID-19 was on February 19, 2020 in Iran. And a little bit of context, the country wasn't well prepared to deal with the situation. And one of the reasons is that it's going through major economic sanctions, which is influencing kind of healthcare resources that exist in the country. And our estimations are for March 20th. So we looked at the problem and offered estimation exactly about like 1 month after the first case of reported cases. Now we are offering those estimations and also reflecting on what happened during the time that we estimated the problem. To motivate the problem, this is one of the messages that my co-author received from a person that was in close contact with a hospital, in one single hospital in north of the country. And they were seeing that, so as you see here, in 1 hour, they had 17 people died in the hospital, and this is just a single hospital. And the situation of the hospital was terrible, and medical staff were thinking about quitting. And with all these stress, you see one single hospital, 1 hour, 17 people have died. And then you look at cumulative official numbers that are reported, is just 19 deaths. So 17, 1 hour, one hospital versus 19 in the whole country in the past 7 days. So just something is not matching, and that raises concern. If we look at graphs over time of the situation, we see how confirmed cases are changing over time. As you see, around March 20th, we have 20,000 cumulative infection and about 2,000 cumulative deaths. And but then there are other indicators of the situation. Travels. So one of the information cues about what's going on about infectious disease is about number of passengers that are leaving the country and are screened upon their arrival in an international airport. So if you look at that and then estimate what percentage of people are traveling, then you can have an estimation of number of cases of infectious disease, assuming that randomly people are traveling. And during the early days, there was a paper that estimated based on the cases that were found in international airports from Iran, and the estimation was 18,000. And you see that major gap between this estimation from flights and the reported number. Unofficial reports also exist from hospitals. A few of them were kind of publicly available. These unofficial reports are coming from CT scan or doctor's diagnosis. And the reason that they might be different from actual numbers is that not all cases are tested because test capacity was limited, and then test accuracy was limited, so many of them were missed. So there was this other parallel channel for estimating numbers that are coming from doctors that are dealing with patients. And if you look at those, number of estimated death was also different from actual cases, especially the last one, which is so far that we plotted on the other graph. So there is this huge difference, and then the question is that what is really happening? We take a dynamic modeling approach, and the basics of the model follows dynamics of epidemics in susceptible, exposed, infected, and recovered models. We also add behavioral responses to the model and also include dynamics of testing. Having this model, then we use a maximum likelihood approach and Markov chain Monte Carlo to identify confidence interval for our parameters. So having the model, we estimate parameters in the model that can replicate the data. Then we use those parameters to estimate the actual number of cases. We use this model to explore the trajectory of the disease in the next few coming months. This is a very simple overview of the model. It is following that basic structure of SCIR. You have susceptible, you have early infected, which are asymptomatic. Then you have late infected, a proportion of them in the case of COVID-19 will be symptomatic. And then some will recover and some will die. The common dynamics in infectious disease exist. A proportion of early infected and a proportion of late infected are those people that are causing more infectious and more exposure in the society. A fraction of late infected are symptomatic cases. And what is happening is that a fraction of that fraction is diagnosed and will be our confirmed cases. So these are ones that are reported, officially reported, and then some of them will die. So those will be our confirmed death rate. And what we are adding in this model is that we are endogenizing social distancing by modeling contact rate as a function of confirmed death rate. So the assumption is that if more deaths are reported, people feel more scared about the disease and contact rate declines. So this way, you see endogenously decreasing contact rate as more confirmed cases are reported. Another mechanism that we are adding to the conventional ACIR model is change in test, which we are including that as an endogenous factor in our model. So here the assumption is that with more confirmed death rate, test coverage will increase because the government feels the need to increase the tests and feels the riskiness of the situation, and then higher fraction of individuals will be diagnosed, which will lead to more confirmed infected. So we are adding these two mechanisms, and this is a simple representation of the main model that we have in the paper. There are two variables that are also providing other information cues. One is death, which is, as described, it's also observed by clinical diagnosis unofficial reports, which you can get cumulative unofficial death reports. And then some of the symptomatic cases, which early on during the very early days traveled and they were diagnosed upon their arrival in other countries. So looking at this model, what is happening here is that our reproduction rate is endogenous. It can change over time as things are changing, and and similarly, contact rate is changing, and test rate is also changing. Our main question looking at this model are about these three variables. We would like to know what's going on here, how the numbers are changing. And the data that we have are about confirmed cases, confirmed infected and confirmed death. Also, in addition, some data points about unofficial death reports and about passengers leaving, and also confirmed recovered, which I'm not showing that in this picture. In addition to these, we have some parameters that are coming from other papers, estimations about the characteristics of the disease. After plugging in all these, we have 9 parameters that are left for model calibration. So we are using all these data sources and infection, death, recovery, and our estimates of passengers and the cumulative death based on unofficial estimates. And then we are using maximum likelihood estimation. And what is happening here is that we are trying to estimate some of the parameters in the model, which we don't have data for them, given the data for official reports and for unofficial reports, and given the model. So we are using that to estimate joint distribution of the unknown parameters. Once you find the joint distribution of those unknown parameters, you can plug in those values in your model, and you run the model for those joint distributions and see what should be the actual number of infected disease to have a consistent model and data. So this is our results. First, the graph on the top, on the left, shows how the model is replicating the cases of infectious reported official reports for both recovered and death, as well as cumulative infected. On the right side, it shows how the model is replicating unofficial data and unofficial death and passengers that were screened. Then you can plug in these values, the parameter estimates that you're getting from the data, and see how your actual cases and death are changing. And this is the surprising result that comes up. The model suggests that the cases should be 50 times more than official reports to have a consistent model with the available data. Also on death, you can see that the model estimates it should be about 11 times more than official data. So these are very alarming, and we can look at other graphs about reproduction number and how that's changing. But these estimations were very far from the official number, so it kind of tells that the situation is way worse than one would expect from the official data. We did lots of sensitivity analysis because some of the parameters are coming from different papers, and see how that's influencing our estimations. Then we did policy analysis. So we had 3 scenarios about weather effect. So we want to see what happens in the future. And we have 2 different policies about, government just leaving it to people to have social distancing, or kind of going taking an additional step and trying to act more aggressively to decrease social distancing. So you have 3 scenarios, 2 policies, you get 6 conditions that you can simulate and see what happens in the future for the cases. As we see here, the cases are increasing, and only in the scenarios that we are both optimistic about better effect and the policies are aggressive, we will see that we can fully contain the disease. Otherwise, the reproduction number reaches around 1 and then stays around that. And that's actually what's happening these days as you look at revisit the situation of the country. We did some post-analysis reflection. So this analysis was done on March 20th, and it was just, we had only 1 month of data back then. Now we have 4 times more. So we did different sorts of analysis to see how the model performed back then. And in some, our model was more successful in predicting or estimating death numbers than infection numbers. And that might be because asymptomatic cases turned out to be way more than what we imagined early on. These are the numbers, the red numbers from the official numbers. We estimated 10 times more for death, or 11 times more for death, and 46 times more for infected. And as you look at other studies that later came on with more data, and there was an antibody testing that found 230 times more cases than the official reports, but just for 1 province. So still kind of considerable. Then all-cause death data was used, and we found that that kind of suggests 7 times more than official reports of death were happening in the country. And that 7 is within our confidence interval for estimates of death. This is a regression analysis that we did post-analysis and after our main analysis, and kind of shows that how we are getting to 7.15 times the magnitude of difference between actual number of deaths and the reported cases. So we also looked to see if the model was able to estimate official reports trends. On the official reports, we were more successful in replicating or predicting future death numbers than future infection numbers. And these graphs kind of tells a story. And we think that the reason that we were more able to predict death rather than infection is that the confirmed infection rate is also is very sensitive to test coverage. And as test coverage changed, after our analysis, then the country started reporting test coverage numbers, and we see that that was increasing, and that has probably influenced the future trend of confirmed cases. So this was a model-based approach to estimate the situation. What we learned is that the test dynamics or the operation of tests can be modeled in more details in our modeling approaches to have a better estimate of reported infection. I would like to take a step back and say that, well, our case was focused on Iran, but this is something that's happening all over the world and can be used in different countries. And as we see in different pieces of news, every country was kind of had a similar situation, including the United States and China and Italy, and Britain. And so the problem of estimating the actual number is all over the world. For a broader reflection, I would say that this was a problem that was about modeling a real time of complex problem. Often we have enough time to go to our office and look at the problems, but here we didn't have that much time. We had to respond. As we were modeling, people were dying. So it is very urgent to do your best and have a timely response. This is one of the things that we learned about the importance of the timeliness in these type of problems and what makes it different from other type of dynamic problems that you have been dealing with. The second thing that we learned was that uncertainties are very important in this problem. And one needs to appreciate all these uncertainties to offer a good or a useful estimates. And in order to do that, there is no way other than using all available data from every sources and also using estimation techniques in our modeling. So we need to improve our modeling process and use advanced estimation techniques to offer confidence interval for our estimations. And finally, these type of problems are complex. They need feedback-rich models. There are many behavioral responses in the society. They are influencing the phenomenon here, COVID-19. So a simplistic view that ignores behavioral responses will fail to fully capture how the disease will impact the society. These type of models need rich feedback loops and include how people are responding to the problems. Thank you for listening to this presentation.